What's up, Ninja Nerds? In this video, we're going to be talking about arrhythmias. But before you guys have an arrhythmia, looking at all the stuff on this board, before we really dig into this stuff and start filling all this out, please go down the description box. In the description box, we'll have links to our Patreon. In Patreon, we're going to have notes, comprehensive notes that what we're going to cover in this whole lecture on arrhythmias. We're also going to have a picture of this board before everything's drawn on it and a picture of everything after it's drawn so that you guys can follow along and benefit as much as possible from this lecture. So please go check that out. So the reason why I'm telling you guys this is that hopefully in the near future, we're going to have a website where every video that we've covered on our YouTube channel will have corresponding comprehensive notes, pictures of the whiteboard with the diagrams beforehand and after the video so that we can help you guys in your learning process. So Ninja Nerds, please go check that out and let's get into this. All right, Ninja Nerds, so let's talk about arrhythmias, right? First thing we need to talk about is the definition of arrhythmias. What is an arrhythmia? If you were really basic, and we ain't basic, but we'll do basic first. An arrhythmia is abnormal electrical activity within the heart. Simple as that. But we're Ninja Nerds. So we really should say that an arrhythmia is when there is an abnormality within either rate, rhythm, sequence of conduction, or origin of conduction. That is the definition of arrhythmias. Now, the easiest way to really kind of define arrhythmias is based upon abnormalities in rate. So the first thing we need to know is what is a normal rate? And once we know what normal is, we know what abnormal is. So what's a normal heart rate? A normal heart rate, which is set by the SA node, the sinoatrial node, when it fires, it sets a normal heart rate of anywhere between 60 to 100 beats per minute. This is considered to be a normal heart rate. If you go above 100 beats per minute, that's abnormal. You're going too fast. How do we define that? Tachycardia. So we can say a tachyarrhythmia is when there is an abnormal rate. How high is that rate? We're talking greater than 100 beats per minute as a tachyarrhythmia. When we go too slow, or we go lower than the 60 beats per minute, we're going too slow, that's bradycardia. So bradycardias are associated, obviously, in this case with bradyarrhythmias, and this is whenever you're going less than 60 beats per minute. Now let's be clear here. You can go way above 100. Sometimes in situations of fibrillation, close to 350 beats per minute or more. So pretty scary stuff. So that's the basic way we talk about arrhythmias. Now that we have the basic kind of definitions of our tachybradyarrhythmias, let's talk about the two subtypes of tachyarrhythmias. And it's really simple. Obviously, everything above the ventricle, any arrhythmia, if I were to kind of draw a line here, any arrhythmia that occurs above the ventricles is called supraventricular tachyarrhythmia. There's one particular one that is usually due to the SA node firing too fast, and that is called sinus tachycardia. Okay? The next type is usually, because let's actually draw this in green so it really sticks out here. There's an irritable area in the atria that's firing. It's generating abnormal electrical activities, and that's going to the AV node before the SA node fires and gets to the AV node. That's called an atrial tachyarrhythmia. There's a couple different types of atrial tachyarrhythmias, and what are they? The first one I really need you to know is when there's just one of these little areas, just one, firing consistently. That's one ectopic focus. So we call it focal atrial tachycardia. Pretty straightforward, right? What happens if you have multiple? Maybe we have three little ectopic areas in the atria that are firing abnormally. That's multifocal atrial tachycardia. Pretty straightforward. What if I have a bunch of little areas that are firing as well, but they also are similar to multifocal atrial tachycardia? I have multiple little ectopic areas that are firing really, really fast, faster than this rate. That could be atrial fibrillation. Okay, so usually we're talking about atrial arrhythmias as usually focal atrial tachycardia, multifocal atrial tachycardia, atrial fibrillation, and one more. There's an abnormal arrhythmia, supraventricular tachyarrhythmia, that occurs near the tricuspid valve that we'll talk about later. And it creates a reentrant circuit, and it's called atrial flutter. And then the last two So we had two categories so far. One is an arrhythmia due to SA node firing. These other ones, 1, 2, 3, 4, is due to an irritable atrial area firing before the SA node fires. The last two here, there's one that's a problem with the AV node. There's a reentrant circuit within the AV node and it's creating really fast rates. And that's called atrioventricular nodal reentrant tachycardia. There's another one where there's a reentrant circuit, a loop that's generated through an accessory pathway between the atria and the ventricles. And we'll talk about that one later. It's called AVRT. Important to remember, you'll hear this term kind of thrown around a lot called SVT or PSVT. And PSVT, also known as paroxysmal supraventricular tachycardia, let's make that look like a better V there, paroxysmal supraventricular tachycardia is a special kind of name that we give AVNRT, AVRT, and sometimes even focal atrial tachycardia. But these are the two primary ones. Okay, so we've talked about the supraventricular tachyarrhythmias, the types. Due to SA node problem, due to multiple atrial arrhythmias, all of these, and due to a reentrant circuit in the AV node, this one, or a reentrant circuit via accessory pathway, AVRT. Let's now talk about the ventricular tachyarrhythmias. So ventricular tachyarrhythmias is you have an irritable area within the ventricle, okay, some irritable area within the ventricle that is firing. And it's firing and generating an abnormal electrical activity within the ventricles. And because of this, this produces particular arrhythmias called ventricular tachycardia. Okay, so ventricular tachycardia. Now here's the big thing that I need to kind of preface really quick. There's two different types of ventricular tachycardia. One is you can have what's called monomorphic, and this is usually the most common type, and we're going to abbreviate this VTAC, monomorphic VTAC. And the other one is called polymorphic VTAC. All this is really simply is if I have one little irritable area in the ventricle that's firing and creating this abnormal tachyarrhythmia within the ventricle, that is monomorphic. But if I have multiple irritable areas within the ventricles that are firing, this is polymorphic VTAC. Just like it was if it was focal atrial tachycardia or multifocal atrial tachycardia, the same concept. One other thing to add on with the polymorphic VTAC is there's two types. This one right here we're going to kind of keep by itself. This is what's called a polymorphic VTAC with a normal QT interval. We'll talk about it later. But there's another special type that always comes up in your USMLE exams, which is called polymorphic VTAC, which is again is a type of VTAC, but it contains a prolonged QT interval. And we give a very special name to this. You know what they give it? Torsades de points, which means twisting of the points. And again, we'll get into this arrhythmia a little bit later. Really nasty one. You see this, you're probably going to poop your Huggies. The next one, you'll also poop your Huggies. And this is a very abnormal rhythm, very dangerous rhythm called ventricular fibrillation. And again, this is due to multiple ectopic foci within the ventricles that are firing, and also they can have what's called reentrant circuits. And we'll get into what all that stuff means later. I'm just prefacing everything here for you. Okay, we talked about the supraventricular, ventricular tachyarrhythmias. The next thing we have to talk about is bradyarrhythmias. Bradyarrhythmias is you're going too slow. We already know that. But again, it could be a problem where the SA node isn't firing fast enough. It's firing too slow. If the SA node is firing too slow, that's referred to as sinus bradycardia. Okay? Sinus bradycardia. The other issue is there could be something wrong with the AV node. It's taking a dump. It's not working today. It says, okay, you send messages to me, SA node. I'll receive them, and maybe I'll send them, but I'll send it slower than I need to, or maybe I won't send any action potentials down. And so there can be a block, if you will, in the AV node, which means that there's a loss of electrical activity connection between the atria and the ventricles. There's a couple different types of conduction blocks or heart blocks, and they're very easy. You want to know why? Because they just have a number in front of them, and we just go in order. So you have a first degree heart block, okay, so first degree heart block, which isn't as severe, believe it or not, I have one, and then a second degree heart block. And a second degree heart block, there's two types. One is referred to as Mobitz 1, and the other one is referred to as Mobitz 2. Now, another name for Mobitz 1 is they have we'll talk about it later, is they have what's called a winky Bach, a dropped QRS. So remember, sometimes you may hear second degree heart block, Mobitz 1, winky Bach, okay? The next one is going to be the most deadly one, can be very deadly if not treated quickly, is a third degree heart block. Okay, so these are due to conduction blocks within the AV node. This is due to the SA node not firing fast enough. This covers our too fast, too slow rhythms. The next thing we have to talk about is there's one that actually is fast and slow, and it's a really odd one, and let's talk about that, called sick-sinus syndrome. Sick-sinus syndrome. So remember I told you it's kind of a combination. That's why you got like nice little blue and red in there. It's mixed. So what happens is they have a tachyarrhythmia associated with this. Usually what happens is the SA node, before we actually say the tachyarrhythmia, the SA node is usually dysfunctional. So because they have some type of SA node dysfunction, whether this be due to fibrosis of the SA node, whether this be due to some type of myocardial scarring, whether this be due to some type of just problem with the SA node intrinsically, as it starts to dysfunction, it doesn't fire as fast. And because it doesn't fire as fast, it produces what? It produces a sinus bradycardia. So that's where you can get some bradycardia. But then what happens is, because of this underlying bradycardia and the SA node being dysfunctional, some other area in the atria has to kind of take over to compensate for the SA node dysfunction. And so sometimes, as a result of this SA node dysfunction, these patients develop an associated supraventricular tachycardia, whether this be atrial flutter, whether this be atrial fibrillation, or whether this even just be like a PAC of some kind, like a premature atrial contraction. And because of that, they'll have intermittent bouts where they'll have sinus bradycardia with compensatory concomitant SVT that produces a tachycardia. So you know, sometimes they call this tachy-brady syndrome. It's like a subset of sick-sinus syndrome. So it's kind of an interesting one where you see kind of an intermingled mix of the two. All right, beautiful. We talked about the types of arrhythmias. We have kind of a nice basic intro into them. Now let's dig into the pathophysiology. All right, engineers, so we talked about the types of arrhythmias. We have our really good foundation down. Now what we need to do is talk about the pathophysiology. What causes these arrhythmias to develop? So we're going to go through each one of these. We're going to have tachyarrhythmias. The most common causes or pathophysiological reasons is usually an increase in automaticity. I'll talk about what that means. Or triggered activity, okay? And the last one is a re-entrant circuit. And we'll go through all three of these and talk about what they mean in great detail. But just again, write that down so you have a little note that these are the three most common reasons for a tachyarrhythmia. Next one is bradyarrhythmias. This is usually due to decreased automaticity or a conduction block. Again, write these down so that when we go through them, you have everything ready to roll. All right, so now that we have our pretty much common reasons for these, let's dig into automaticity first. All right, so first thing we need to talk about is we know that tachyarrhythmias, bradyarrhythmias, you see how they're both the same color, different colors. They have the ability to increase or decrease automaticity associated with those arrhythmias. Okay, and we'll talk about some of the underlying causes. But first, before we do that, let's talk about what the heck automaticity is. What is automaticity? It's really simple. You know, whenever the SA node, it has those little, remember we talked about this in the cardiovascular system. If you haven't watched our video, go in, watch the video on the intrinsic cardiac conduction system in our cardiovascular playlist. We go into more detail here. I'm going to kind of cover the surface a little bit here. But if you guys remember, the SA node has special little channels called funny channels, which allows for it to kind of intrinsically, on its own, depolarize, send action potentials, and cause the heart to contract on its own without any nervous system innervation, on its own. And how it does that is, again, the SA node fires, goes down to the AV node to the bundle of Hist, down your bundle branches, and then through your Purkinje system. That's our normal kind of conduction pathway. The normal automaticity rate is 60 to 100 beats per minute. What if I have some modulation of that normal automaticity? Ooh, well, Zach, that kind of makes sense, right? Darn right it does, because we're engineers. We make sense of stuff. What if I have something like the parasympathetic nervous system? You know cranial nerve 10, parasympathetic nervous system. So you know cranial nerve 10 is also known as what nerve? I know you guys know this, vagus nerve. The vagus nerve, or cranial nerve 10, releases a lot of what onto the SA node or the conduction system in general? It releases a lot of acetylcholine. And acetylcholine, you guys know what that does, right? It causes potassium ions to leave the cell, hyperpolarizes it, and relaxes it, and then it does what? It decreases the conduction from the SA node and decreases the movement of conduction from the AV node down. What does that do? That drops the heart rate. And if you drop the heart rate, what is that called? bradycardia if you drop it below 60 beats per minute. That could be one of the reasons for a bradyarrhythmia. So again, this is usually what system here with the cranial nerve 10? This is the parasympathetic nervous system. But what if I have the sympathetic nervous system? You know the sympathetic nervous system? The normal sympathetic nervous system within the spinal cord is about T1 to L2, right? But going to the heart, out of that T1 to L2 output, only T1 to about T5 of your sympathetic nervous system goes to innervate the heart. Now it does two things. It can innervate not just the SA node, but it can also innervate contractile myocardial cells. But let's not focus on that one right now. What I want you to know is that when the sympathetic nervous system releases what kind of neurotransmitters here? It releases an increase in norepinephrine or an increase in epinephrine. What do these things do? They increase the conduction via the SA node and increase the conduction through the AV node down. That's going to increase heart rate. That's going to increase automaticity. And if it goes above 100 beats per minute, it's considered to be a tachyarrhythmia. Wow, we just made sense of this stuff. So what would I say then? If I have too much sympathetic nervous system outflow, I'm going to drop the heart rate. I'm going to increase the heart rate really high. But if I have a lot of parasympathetic outflow, I'm going to drop the heart rate really low. So now we have to talk about what are the things that increase the sympathetic outflow and what are the things that increase the parasympathetic outflow, because that's our underlying causes. Okay, so first one we have up here, let's just go in order, the top one. The parasympathetic nervous system we said is going to drop the heart rate, right? And again, what do we say if we drop the heart rate? It's called a decreased in automaticity, right? So a decreased automaticity. And sometimes if we drop that kind of heart rate down enough, it can lead to a bradyarrhythmia, which can become sometimes symptomatic. We said one of the reasons, because there is other reasons, one of the reasons is due to increased vagal tone. So there's an increased vagal tone or increased parasympathetic nervous system activity. You know what's crazy? Is that sometimes this increased vagal tone can be completely physiological or normal. You know, whenever people are sleeping, they're resting, they're digesting, you know, they're doing all that stuff. Their vagal tone is a little bit higher because their parasympathetic nervous system is a little bit more active when we're sleeping. So that may produce some bradyarrhythmias while you're sleeping, or bradycardia in general. The other thing is it could be due to endurance athletes. You know, certain athletes, endurance athletes, their myocardium is so strong and so powerful that they can have a higher vagal tone associated with it. So that could be another reason. It says endurance athletes with very powerful myocardiums have lower resting heart rates. A pathological reason for an increased vagal tone is usually an associated inferior wall MI. This can kind of create like a reflex vagal tone. So inferior wall MIs are usually due to what coronary artery? A right coronary artery occlusion. So think about right coronary artery occlusion producing an inferior wall MI. That also can produce some increased vagal tone. Other things that can do this is think about, what if I not just increase the parasympathetic tone? What if I actually gave drugs that kind of like block not block it, but slow down conduction through the AV node? You know, there is certain drugs that can kind of slow down conduction through the AV node. What are those drugs that basically slow AV conduction? Because if we slow AV conduction, we're also modulating the automaticity. This would be things like beta blockers, things like calcium channel blockers, or things like digoxin. So that's another thing to be thinking about. Okay, so not only if we slow AV conduction, right? But what else? So it can either increase vagal tone, that would decrease automaticity. We can have slower AV conduction, but also another thing is, what if I kind of really slow down the metabolic activity of these nodal cells, right? So if I slow down the metabolic activity, that could also maybe slow down some of these depolarizations. So certain things that can really kind of decrease metabolic activity is going to be like a low body temperature, you know, hypothermia. So if somebody is out there, you know, hiking out on Mount Everest or something like that, and they get too cold, maybe they can develop some decreased automaticity. But other reasons is, think about a hormone that really controls a lot of our metabolic activity, thyroid hormone. So sometimes if people are really severely hypothyroid, like in a condition called myxedema coma, where they can have really, really low thyroid hormone levels, this can also produce some severe bradycardias and a decreased automaticity. So that could be another reason. Another one is usually due to an electrolyte imbalance. And the particular electrolyte here is if they have too much potassium, okay? So hyperkalemia could be a very powerful reason, a big one that I really want you to remember, that can cause decreased automaticity because it alters that resting membrane potential, and that really affects the electrical activity within the heart. The last one that is always coming up on your exams is due to high intracranial pressure. Someone has high intracranial pressure, whether it was due to a stroke, whether it's due to a tumor, whether it's due to some type of hematoma or mass. It causes a lot of pressure that can cause brain herniation. And whenever it leads to this brain herniation, this can lead to a very particular triad called Cushing's triad. And one of the components of Cushing's triad is low heart rate. They also have hypertension, and they can have irregular, I'm going to put IR, respirations. So they can have irregular respiration rate, a low heart rate, and hypertension due to high intracranial pressure. So again, this one will come up on your exams. Probably doesn't happen that often though in real life. But again, think about that. Decreased automaticity. What reasons? Increased vagal tone, slowing AV conduction, decreasing metabolic activity. Don't forget this one, hyperkalemia, and high intracranial pressure, leading to Cushing's triad. The other thing is what is going to increase the automaticity. So now let's talk about those factors that increase the automaticity. Okay, we already know the primary one. The big one that I want you guys to take away is the sympathetic and parasympathetic tone, right? So automaticity. So automaticity, we said the big one, main reason is increased sympathetic nervous system tone via the T1, T5 outflow. Big reason, really need you guys to remember this one, hypovolemia. If someone is hypovolemic, that can be a primary reflexive type of thing. So whenever someone's has low blood volume, it leads to low blood pressure. You guys remember our video on blood pressure regulation? If not, go watch our video. A low blood volume, low blood pressure creates a reflex, which activates your sympathetic nervous system. Sympathetic comes and increases heart rate and does what? Vasoconstricts the blood vessels. So that's one way that our sympathetic tone is kind of a reflexive thing. The other reason here is usually due to hypoxia. So some type of underlying hypoxia. You know, hypoxia is when there's low oxygen delivery to the tissues. There could be many reasons. If you guys haven't watched our video on hypoxia, go watch our videos on hypoxia as well. But usually this could be due to low red blood cells. So if someone has anemia, very severe anemia, if they have maybe some type of underlying lung disease like COPD, or you know what else? What if they have some issue where there's a clot in their pulmonary vessel, like the pulmonary artery, and blood's not getting to the lungs to oxygenate? Pulmonary embolism. This is actually one of the most common arrhythmias associated with pulmonary embolisms. People always say it's that S1, Q3, T3. No, sinus tachycardia is the most common arrhythmia associated with pulmonary embolism. So again, don't forget PE as another potential cause. All right, so these are some of them. Another one, don't forget about this one, is what if someone is taking a drug that acts like epinephrine and norepinephrine? It's kind of a sympathomimetic. That could be another reason. And the big thing you need to remember is usually certain types of drugs like what? Sympathomimetic. Sometimes I got to catch my brain up with writing, sorry. Sympathomimetics, this is usually things like cocaine, methamphetamines, or drugs that we use to increase people's heart rate. Okay? The other thing is, besides sympathomimetics, so drugs that mimic the sympathetic nervous system, is sometimes just, remember, your hypothalamus is a part of your limbic system, so sometimes if people are experiencing pain or anxiety, that can activate the hypothalamus, activate the sympathetic nervous system, and again, increase heart rate. So also be on the awareness of particular types of pain or anxiety as other causes of this. The last thing is if you increase metabolic activity of your cells. If you increase metabolic activity, that may increase the electrical activity. And this is associated with opposite of what was decreased. So it's going to be seen with fever, and it's also going to be seen with hyperthyroidism. Okay, so hyperthyroidism. Now, the last thing that I want to say before we move on here is that what type of arrhythmias are usually associated with a decreased automaticity, and which ones are associated with an increase in automaticity. So decreased automaticity, I want you to be thinking about what type of arrhythmia. I want you to be thinking about sinus bradycardia, okay? Whereas in someone who is actually having what? Increased sympathetic tone, which is causing increased vagal tone, this is most commonly associated with sinus tachycardia. You can see this with some atrial and ventricular arrhythmias, but this is going to be the most common cause for these arrhythmias. Okay, now that we've drilled that, let's move into triggered activity. All right, so we finished up talking about automaticity. Now the next type of cause for underlying tachyarrhythmias is triggered activity. Really simple, straightforward. What happens is, you guys know you have your normal conduction system, SA node, AV node, bundle of His, bundle branches, and Purkinje system. That's our normal conduction system. Let's say that you develop an irritable area, right? Some irritable area within the ventricular myocardium or some irritable area within the atrial myocardium. And because it becomes irritable due to these underlying causes, which we will discuss, it starts firing. And because it starts firing, it's not following what? Your normal sequence of conduction, going SA node, AV node downwards. It's going from an ectopic area, an ectopic pathway. Because of that, that's considered to be an arrhythmia. That was the definition of arrhythmia. What are the underlying causes for these areas becoming triggered? That's important. The first thing that you need to know is, let's say we zoom in on either of these cells. We'll just pick the ventricular one for this case. Let's say this cell's become irritable. When it becomes irritable, it starts producing a particular type of abnormal depolarization called an early after depolarization. Again, we'll talk about what this means. Whereas in this cell, let's say it's also becoming irritable. It's just another type of cell. It becomes irritable and it produces what's called a delayed after depolarization. And again, we'll go over these in more detail with these graphs here. But the reason why I'm telling you this is that EADs and DADs have different underlying causes and produce different types of arrhythmias. EADs are most commonly associated with what? It's most commonly associated with electrolyte imbalances like low potassium, low calcium, low magnesium. Or it also can be associated with particular drugs. And this is super important. We're going to create a little mnemonic for you. A, B, C, D, E. Anti for all of them. Arrhythmics. Which ones? 1A, 1C, these are your sodium channel blockers, and 3, potassium channel blockers. Antibiotics. The most common ones are going to be your macrolides, right? So these are your mycins, azithro, erythro, clarithromycin. Then your we're not spelling it right, but it's going to help with the mnemonic, psychotics, and this is going to be like haloperidol. Another one is called ziprasidone, okay, or risperidone. There's many different types of other antipsychotics. And then the next one is antidepressants. And the big one here is going to be your tricyclic antidepressants. But the other ones that you want to be taking into consideration are also, to a smaller degree, your SSRIs. So TCAs, tricyclic antidepressants, these are another potential trigger. And then the last one here is going to be your antiemetics. And this is going to be something like ondansetron, which is also known as Zofran, right? When we talk about its brand name. All right, these are very strong triggers for EADs. So again, I want you to remember that all of these particular things here are very strong triggers for these myocardial cells, and then from that they produce an early after depolarization. Remember these causes. The next thing is, what are the underlying causes for delayed after depolarization? They're less clear, a little bit more ambiguous, but the big one that I don't want you to forget, the most common reason, is going to be underlying ischemia. So if someone has some underlying ischemia, maybe they're having an active MI, right? So they're having an MI or they're having some type of coronary artery disease of some form. And this is producing some irritation to these ventricular atrial cells. Other reasons is because you could have some type of underlying hypoxia. And this hypoxia could be due to a lung disease of some form or maybe other reasons as well. It also could be due to inflammation. You know, there's particular inflammation of the myocardium. What's that disease called? Myocarditis. That could be a very potential intense one as well. Another reason is because you're really stretching the myocardium. And as you stretch the myocardium, believe it or not, it really alters the activity within those cells, their normal depolarization, repolarization. What are conditions that really stretch out the myocardium? Dilated cardiomyopathy and mitral regurgitation are two big ones. So again, ischemic causes, hypoxic inflammation, stretch associated with these two diseases. The next one, really important one, is some increased sympathetic tone due to any of the underlying reasons we talked about over here with increased automaticity. That could also trigger that. And the last one that I want you to remember here is DIG toxicity. So digoxin toxicity can also precipitate some of these effects as well. When these cells are irritated due to these underlying causes, they generate a delayed after depolarization. Why am I stressing so much on this? Here, let me explain why. So why am I stressing so much on knowing these EADs and DADs? The reason why is, remember I told you, EADs and DADs produce a special type of arrhythmia. The really big one that I want you to remember is that EADs are commonly associated with a particular type called a polymorphic VTAC with a long QT interval. What do we call that, guys? Torsades de points. Okay, really important to remember that. So what in the heck is an EAD? Believe it or not, it's really simple, okay? Let's say you take that normal contractile myocardial cell, and when you look at this, it has this normal kind of waveform where it has a depolarization due to sodium ion influx, a plateau due to calcium influx and potassium leaving, and then a repolarization due to potassium leaving. This is kind of their normal depolarization and kind of like contractile waveform. Now, let's say that at this point here, as the cell's in its plateau phase, you agitate the living crap out of this cell. And because of the low calcium, potassium, magnesium, or drugs, it becomes so agitated that it comes out of repolarization and starts firing. That can produce that torsades de points. So that's really the underlying cause, and the underlying kind of mechanism behind these EADs is early depolarization that comes just after the previous depolarization from the normal contractile myocardial cells. In the opposite situation here, let's say that we talk about a DAD, a delayed after depolarizations. These are commonly seen with multifocal atrial tachycardia, focal atrial tachycardia, and also VTach, but not the polymorphic VTach with prolonged QT, monomorphic VTach, and polymorphic VTach with normal QT intervals. Very important, okay? So once we have that, the same mechanism, but again, I'm telling you guys, it's so simple because it's literally within the name. Normal waveform, we already talked about this. But all that happens here is that instead, this was early after depolarization. So the normal depolarization is this up one, and you're still depolarizing in this kind of like somewhat of a plateau phase. So right here is you're still kind of depolarizing. As you go down, you're repolarizing. So at this point, it's a little bit later after depolarization has occurred at this point and this point. So maybe about right here, this ventricular myocardial cell or atrial myocardial cell is going to start causing some of these irritable depolarization waves, and these are called your DADs, okay? So again, that gives us the underlying mechanism and the arrhythmias associated with these particular pathophysiological mechanisms. Now let's go into reentrant circuits. All right, so the next type of pathophysiological mechanism I want to go through is reentry. And again, this is associated with the tachyarrhythmias. What is reentrant circuits? Before I start these, I want to preface that reentrant circuits are usually seen in a couple types of arrhythmias, and we'll explain some of these in more details than others. The ones that we'll talk about a lot is your AV NRT and AVRT, which we said these were kind of your SVTs, if you will, right? So we kind of called this your what? Your paroxysmal supraventricular tachycardia, or SVT. The other ones that are associated with reentrant circuits, a really interesting one is atrial flutter, but another atrial arrhythmia called atrial fibrillation. And remember we said VTach could also be associated with triggered activity? VTach and VFib can also be seen with reentrant circuits. So there's other reasons that they can also generate arrhythmias besides triggered activity. It could be they have little reentrant circuits, and we'll talk about what those are. The one that I want to spend a little bit of time first discussing with is the AVRT. This is a really interesting one. So let's talk about this one here, and this is the AVRT. Again, what does that stand for? Atrioventricular reentrant tachycardia. What happens in this? First thing you need to know is that atrioventricular reentrant tachycardia is due to an underlying accessory pathway that exists between the atria and the ventricles. Most common area is usually left atrium, between the left atrium and left ventricle. Sometimes it's called, AVRT is usually seen with Wolff-Parkinson's-White syndrome, right? That's one of the most common subtypes of AVRT. Usually there's this accessory pathway in this between left atrium and left ventricle, and it's called the bundle of Kent. So what is this accessory pathway called? So you have what's called an accessory pathway. And the most common type here is going to be the bundle of Kent. There is another one called the bundle of James. You might see that also in your studies, and it's associated with Long-Gonong-Levine syndrome. But this one is the big one because the bundle of Kent is seen with Wolff-Parkinson's-White syndrome. Now, What the heck does this accessory pathway do? Well, remember, it's like an electrical window. In other words, if you have some electrical activity that's coming from the atria down through this, it can pass information down to the ventricles. If you have information coming from the ventricles, it can pass information up to the atria. So it's a bidirectional accessory pathway. That's very important. You want to know why? Because there's two different types of a Wolff-Parkinson's-White syndrome, or again, AVRT. The first type that I want us to talk about is the most common type, and this is called orthodromic AVRT. Orthodromic AVRT is going to be the most common type of, particularly AVRT, and this right here is usually whenever you have electrical activity that can start at the SA node, right? It can even start somewhere else, but SA node generally going to the AV node. But here's the important part. It goes down the AV node, through the bundle of His, down your bundle branches, down your Purkinje's, depolarizes the ventricles, right? Normally, in a normal conduction pathway, it stops there. The ventricles depolarize, then they repolarize, and then the SA node fires again. But guess what? These individuals, some underlying congenital cause, they have this tissue. Guess what happens? When the ventricles depolarize, they can pass right back into the atria, come back down, stimulate the AV node, and go back down the circuit again. And if they have fast atrial rates, this can produce really high tachyarrhythmias, pretty fast ones sometimes. So this is called orthodromic AVRT, and the big thing I want you to remember is it goes down which way? It goes down the AV node and comes up the bundle of Kent. That's important for another reason. Why? If it goes down the AV node and up the bundle of Kent, it's following your normal conduction pathway. That means that the ventricles are going to depolarize at the same time, right and left. That produces a narrow QRS complex. Remember that. Orthodromic AVRT, narrow QRS. What did I say? Orthodromic AVRT, narrow QRS. Why am I stressing that? There's another type of AVRT called antidromic AVRT, way less common, but again, a little bit more lethal. Reason why is this electrical activity goes the opposite direction. If the atria is firing, it'll go where? Through the atria. Instead of going through the AV node, it'll go through the bundle of Kent, come up through the ventricles, depolarize the bundle branches, depolarize the bundle of His, AV node, come back into the atria, and then move back down the bundle of Kent again. That is the dangerous one. You want to know why? Because if someone's having like AFib or something like that associated with this antidromic AVRT, that means every atrial fibrillation kind of firing that they have will be able to go through this accessory pathway completely unregulated, and the atrial rate and ventricular rate can almost equal one another. Big thing to remember, bundle of Kent is not as regulated as the AV node. AV node conducts slower. Bundle of Kent will conduct things really fast. So that can be really dangerous. Also, with antidromic AVRT, think about it. Is it following the normal conduction pathway? SA node, going through the atria, going down the bundle of Kent. No, it's not going down the AV node and downwards. So because of that, because it's going which direction? Down the bundle of Kent and up the AV node, it's not following the normal conduction pathway, and that produces a wide QRS complex. That's important to remember, okay? That's how we kind of differentiate these two, really. Now, that discusses our AVRT. The next thing I want to talk about is the AV-NRT. Remember I said we were going to focus on two of these primarily. With AV-NRT, there's an abnormal pathway that is developing within the AV node. All right? We said AVRT is usually like a congenital cause associated with this bundle of Kent. AV node usually has some type of underlying cause which we have to talk about. But there's an abnormal pathway. So what I want us to do is zoom in on the AV node, look at this abnormal pathway, and talk about the underlying causes of it. So again, we're zooming in on this AV node here, right? So here's going to be our AV node. And just to give you kind of some information, let's say that this electrical activity coming here, it's coming from the atria, maybe from the SA node. And it's coming down into the AV node. And what it would leave, what's after the AV node? What would this structure here be? We'll abbreviate it. Bundle of His. What would come after the bundle of His? The right bundle branch. What would come after this side? The left bundle branch. So we kind of have our normal kind of flow here that we know about our normal conduction system. Let's say the atria fires. When the atria fires, normally it goes down through the AV node, moves through it completely, and into the bundle of His and the bundle branches. But in people with AV and RT, they have an abnormal pathway. And the reason why is usually there is some type of underlying fibrosis or scarring that is occurring within the AV node. What is the reason for this scarring or this fibrosis? This could be due to, again, what is this associated with this? AV and RT. This can be seen with myocardial scars. Maybe they had a history of myocardial infarction. Maybe they've had heart surgery before, and that's the reason for the scarring that's occurring during the AV node. Or maybe they have some type of fibrosis. You know, as people get older, they can develop some idiopathic fibrosis that can occur within the AV node as well. So scarring, fibrosis, these could be some reasons. Because of that underlying scarring or fibrosis, it produces two abnormal pathways that occur within the AV node. Let's talk about these. This pathway here, which we're going to talk about, it's alpha pathway. This pathway here is called the beta pathway. Big thing I want you to know. Alpha pathway versus the beta pathway. Really straightforward here. With the alpha pathway, big thing I want you to know is that they have slow conduction. They don't conduct action potentials through that pathway very fast because of the underlying, usually fibrosis of that area. Whereas in the beta pathway, there's usually fast conduction. So it's producing it really fast through this area. The underlying thing here is that these have slow, fast conduction, but alpha pathway, because it conducts slowly, it kind of repolarizes and goes through its refractory period much quicker. So it has a short refractory period. Whereas in the beta pathway, this has a long refractory period because of its underlying fast conduction. Let's explain what the heck that even means. Atria fires, moves down through the atria into the AV node. As it comes into the AV node, it can bifurcate into these two areas. Which way would it go? Well, it can go into the alpha pathway and then go into the beta pathway. Remember, alpha, it's going to move really slowly, okay? And the beta pathway, that thing is going to fly like a motherfucker. It's going to fly through here, and it's going to go down the bundle of His into the bundle branches, and then down into the ventricles, depolarizing the ventricles. But it moves so fast that it goes up the beta pathway. And as it approaches this kind of wave coming down here, they both cancel each other out. And then depolarization within the AV node ceases. After depolarization ends, what has to happen? Repolarization. So they start going through their refractory period. Now remember, if we were to have the next stimulation here from the atria coming down into the AV node, think about this here. Which one is going to come out of refraction first? The alpha pathway. But what's going to happen to the beta pathway? It's not going to be out of refraction. So let's kind of highlight that here. Let's put like a kind of a dark green thing here saying that, hey, you can't stimulate me because I haven't come out of my actual refractory period because it's longer. You can go down the alpha pathway though. So what happens is next time the atria fires and it comes into the AV node, it'll bifurcate and go only this way through the alpha pathway, go down the bundle of His to the bundle branches, go down, depolarize the ventricles. Here's the thing though, and it's so cool, because it moves so slow down this actual alpha pathway and gets down here to go to the ventricles, by the time it gets down to this point, guess what else happens? This beta pathway starts coming out of refraction. As it comes out of refraction, watch what would happen. Let's imagine we kind of skip forward a second here. It kind of comes down this pathway here. We're already at this point here, right? This whole thing came out of refraction. This sent this impulse down into the ventricles. Ventricles depolarize. Then what happens? This has already come out of refraction. So guess what? These waves come up the beta pathway. As they come up the beta pathway, they send electrical activities up to the atria, cause the atria to depolarize. Then it moves back down the alpha pathway, sends an action potential down to the ventricles, and comes back up the beta pathway, sends another electrical activity, and goes back down. Do you guys see the whole point here? It's creating a reentrant circuit that's not going to stop. And because of that reentrant circuit, every time it's going through the circuit, it's spitting off these electrical kind of like vectors that are going into the atria and into the ventricles and causing them to depolarize at fast rates. That's why this can be problematic, and that's the underlying mechanism. Big thing I need you to remember is there's two ways that this can happen. The most common type of AV and RT is going to be when it goes alpha to beta, or we say slow, fast pathway. Okay? So going this, which we just talked about, is the most common. Really uncommon for it to go the other direction. Okay? Fast, slow. That discusses that. Let's finish up talking about these other really smaller ones, atrial flutter, AFib, VTach, VFib. So really quickly, let's talk about atrial flutter. The only reason I wanted to mention this one is because there is this abnormal reentrant circuit that occurs right here at the tricuspid valve area. At the tricuspid valve, there's this really abnormal reentrant circuit. And so atrial flutter has a large reentrant circuit near the tricuspid valve, or we call this the cavo-tricuspid isthmus. And this can produce some really nasty rates as well. So again, cavo-tricuspid isthmus can produce reentrant circuits that are pretty fast. Okay? Now, the next thing we have to talk about is AFib, VTach, VFib. Okay? With atrial fibrillation, you get multiple little irritable areas within the ventricles that create their own reentrant circuits and then fire things down into the AV node and down to the ventricles. With VTach, again, one little irritable area that can generate reentrant circuits as well. VFib, multiple little areas that are generating reentrant circuits. So the whole thing that I want you to understand here is the underlying reason for AVRT, AVNRT, talk about this slow-fast pathway, and then talk about this large reentrant circuit with atrial flutter and multiple reentrant circuits with AFib and VFib and a large reentrant circuit associated with VTach. Okay? Now that we understand this, let's finish up with conduction block. All right, engineers, so let's finish up with the last pathophysiological reason for these arrhythmias. So we talked about how bradyarrhythmias are associated with decreased automaticity, right? We already talked about that, and we finished up all the underlying reasons for tachyarrhythmias. The last reason for bradyarrhythmias is a conduction block. This is really easy. It's pretty much just like the sinus brady. It's just we really shut down that AV node. Instead of slowing AV conduction, we really kind of shut down AV conduction pretty hard. So some of the reasons are actually going to be the same. So what would be some reasons I shut down this AV node? What if I just completely kick the blood supply that's going to it? What is that called? An MI. So the right coronary artery generally supplies this AV node. So if someone develops what's called an inferior wall MI due to a right coronary artery occlusion, that could be one potential reason for that AV node being jacked up and not sending action potentials down into the ventricle. The other reason is due to underlying fibrosis. So what if somebody has some underlying fibrosis of this AV node, and because it's fibrotic, it's not conducting electrical activity as well, so it's slowing down or really not allowing electrical activity to move down through it and into the ventricles. That could be another reason. Another really big one we talked about over there, but don't forget it, guys, is hyperkalemia. If someone has really high potassium, it really alters the electrical activity within the resting membrane potential. The next thing that you have to be thinking about is drugs. What if I give drugs that really just shut down or block the conduction through the AV node? What if I give things like beta blockers? Or what if I give things like calcium channel blockers? Or what if I give things like digoxin? These are all drugs that can really shut that down as well, okay? The next thing I need you to be thinking about is what if there's some type of infiltration? I put deposits in the AV node. I really deposit that thing up. What if I have certain infiltrative diseases? So infiltrations from conditions that are rare, but you should know them, amyloidosis or sarcoidosis. These are potential things that you want to be thinking about as well. Okay? The next really big one that you guys can't forget, it comes up a lot, is there's a nice little bacteria that really jacks up this AV node, and it comes from a tick. It's called Lyme's disease. So Lyme's disease is another potential reason that someone can develop this. So again, Lyme's disease is usually due to a bacterial infection caused by the Borrelia burgdorferi. There can be other reasons, like if someone is developing some type of underlying cardiomyopathy that's kind of really changing the overall structure of the myocardium, but these are going to be some of the most common reasons for someone experiencing a conduction block. If you guys remember the most important ones, do not forget inferior wall MI, Lyme's disease, beta blockers, and high potassium. These are going to be the big ones that you guys really need to remember for the conduction block. Boom, roasted. Let's move on to talking about the EKG differences and treatment. All right, engineers, so now let's talk about the EKG differences between these arrhythmias and then come up with a nice little treatment plan. So how do we go about this? Nice little algorithm. First thing, determine too fast, too slow. If it's too fast, it's a tachyarrhythmia. Too slow, bradyarrhythmia. Let's say we start with the too fast. It's too fast. We know it's a tachyarrhythmia. It's one of these 4 categories. How do I figure out which category it's in? First thing I do is, after I find out that it's too fast, I check my QRS complex. That's my first thing I do. So I'm going to go ahead and I'm going to draw out here just a quick little diagram of a QRS complex. First thing I need to know about my QRS complex is the width. The normal, kind of like what you would like it to be, is if it's less than 0.12 seconds, that's normal. And so since it's going through your normal conduction pathway, AV node, bundle of His, bundle of branches, then we consider that to produce a nice little narrow QRS. That's good. Okay, it means we're following our normal conduction pathway. If it's greater than 0.12 seconds, that means we're not following the normal conduction pathway. It's not going from AV node down to the Purkinje. It's hitting a block, or it's the origin of the actual rate is coming, or the origin of the conduction is coming from some other area. So because of that, that produces a wide QRS complex. So too fast, narrow, wide. Now I have my narrows and I have my wides. Well, what's the difference between these? Well, now I can categorize these, but now the next thing is it regular or is it irregular? How do I determine that? The next thing is I'm just going to draw a couple QRS complexes here, right? If I draw a couple QRS complexes, you have the upright wave. The upright wave is your R wave, right? What I want to do is I want to measure the distance from the R to R to R to R to R to R to R, right? So that's called your R to R interval. The R to R interval, what I want to do is I want to measure the distance. If the distance between each R wave is the exact same, that is a normal, kind of regular R to R interval, so it's considered to be a regular rhythm. So if the R to R interval is constant, so we'll put normal R to R interval, right? Then that is going to produce a regular rhythm. If it is not a consistent, or there is an abnormal R to R interval, then that is an irregular rhythm, okay? So that's the first thing I do. Now let's take it just one extra step here. When you're looking at these 12-lead EKGs, you get these little boxes on the EKG. How the heck do I know if it's greater than 0.12 seconds, Zach? One little tiny box on the EKG is about 0.04 seconds. So 3 little boxes, 0.04 times 3 is going to be 0.12 seconds. If it's greater than 3 little boxes, that would be what? A wide QRS complex, okay? And then the next thing is, when you're looking at your EKG, just take a piece of paper and just put a little line on the piece of paper, line it up with 2 R to R intervals. Put a line on that piece of paper, line on that piece of paper. And then just keep tracking at each point of the way to see if the R to R intervals match up with that little thing that you drew on the paper. If it does, it's normal. If it's not, it's irregular. Pretty simple trick, right? Okay, boom. Too fast. We've now categorized it into narrow or wide, and we know if it's regular or irregular. Now, what are the differentials within these groups? Nice and nice. I'm glad you guys asked. I know you guys are asking, right? Narrow QRS, regular. I want you to think of a couple. First one I want you to think of, we're going to abbreviate these, sinus tach. The next one is focal atrial tachycardia, FAT. Or it could also be AV-RT or AV-NRT. What do we kind of group this as? Your SVTs, right? We kind of call this your PSVT, paroxysmal supraventricular tachycardia. And the last one is atrial flutter. Now, that is our differential for narrow QRS with a regular rhythm. What if it's a narrow QRS irregular rhythm? The first one that I want you to be thinking about. First one on the top of your differential should be atrial fibrillation. After that, the next one is atrial flutter with a variable block. I'll talk about what that means and how to identify it. And then the last one is multifocal atrial tachycardia. Okay, so narrow QRS regular, we know the 4 in the differential. Narrow QRS irregular, we know the top 3 in the differential. Wide QRS regular rhythm. First one, no matter what, you better think this right at the top of your head, VTAC, right? We'll put TAC, VTAC. And VTAC, when we're talking about this one, is a particular type of VTAC. You see all the QRS waves that we're going to be talking about? They're all the same morphology. So because of that, what did we say that was called? Monomorphic VTAC. The other types is going to be SVT, supraventricular tachycardia, so one of the AVRT or AVNRTs, with aberrancy, which is called a bundle branch block. So there's a block, and we'll talk about what the heck that means in a second. And the last one is going to be antidromic AVRT. Okay, this is the least common one, probably the lowest on the differential. The two big ones that I want you to remember is VTAC and SVT with the bundle branch block. The last thing is if you have a wide QRS and an irregular rhythm, then what do we have? This is your polymorphic VTAC. Remember, there was two types of polymorphic VTAC. One is you had the normal QT, and the other one is you had the long QT interval, right? And what do we call the long QT interval? Torsades de points. So don't forget about that one. We'll put TDP, torsades de points. The next one, and again, you see this one, so it's probably gonna poop your huggies, AFib with Wolff-Parkinson's White syndrome. And the last one, which believe it or not, is actually one of the most common types of wide irregular rhythms, is AFib with aberrancy, meaning it has a bundle branch block. And then there's one last one, but it's usually a result of a breakdown from polymorphic VTAC or AFib with Wolff-Parkinson's White syndrome. And this is called ventricular fibrillation. You see this one, not good. You got to get immediate kind of CPR going. All right, so we now have categorized all of our tachyarrhythmias beautifully. We have our differential of which one it could be. Now what we got to do is we got to take a look at some of these EKGs and say, okay, which one would it be if I see this, this, and this? And here's the great thing. Here's what's nice about this. Some of these, even if you can't identify the difference, you can treat them empirically and see which one improves, and that usually helps you to differentiate which rhythm it is. So now let's go ahead and talk about the EKG differences. Let's talk about our differential. Let's get into a little bit more detail. So we have our differential, sinus tach, focal atrial tachycardia, SVT, atrial flutter. Which one is it? How do we identify it? First thing, let's look at this first EKG. When I look at this EKG, the first thing I want to know is it sinus rhythm? In other words, how do I determine if it's sinus rhythm? Is there a P wave that I see visible before every QRS complex? That's the first thing I want to know. So let me write that down. Is it sinus tach? How do I determine if it's sinus tach? Is there P waves present? Okay, yes, there is. Let's take it one step further. When you're looking at a 12-lead EKG, the best way I've found to determine if it really is sinus is you find P waves, and we're going to put an up arrow. Those P waves are upright in lead 2, but they are inverted. We'll put a down arrow in AVR, meaning that they kind of look like a U. That is one of the big identifiers that it's most likely sinus tach. So I see P waves upright in lead 2, inverted in AVR. Ooh, this probably is sinus tach. Do one more thing to make sure. Make sure that after every P wave is a QRS complex, and after every QRS complex, there is a T wave. If it is, it's normal sinus rhythm. But there's some tachycardia occurring with it where you're actually going a little bit too fast. That's the first thing. Now, how fast do these usually go? So sinus tach, it usually doesn't get above 150, okay? It can sometimes, but usually doesn't get above 150. So that may be another small identifier. All right, we knocked that one out. The next thing is, I'm gonna look at the next EKG. Oh, Zach, what is going on here? These P waves are there, but they don't look the same. They're actually inverted. Huh, but there is after every P, there's a QRS and then a T wave. So it looks like sinus, but the P wave isn't upright. Assume I'm talking about this as lead 2. So this arrhythmia here is focal atrial tachycardia. Usually one of the most common presentations of focal atrial tachycardia is an inverted P wave. The reason why is, remember your electrical depolarization from EKG basics video. SA node down to AV node creates a depolarization vector that kind of goes downwards towards the left, pointing towards the positive electrode of lead 2. If the left atria, let's say that there's a little focal area that's firing from the left atrium, and it's depolarizing the atria moving in this direction, away from the positive electrode of lead 2, what does that cause? An inverted P wave. That's usually the most common type of focal atrial tachycardia. So it's going to look opposite of sinus tach for the most part. So they'll have P waves, but guess what? They will be inverted in lead 2 and upright in AVR. Woo-wee. And there's a P, a QRS, and a T wave usually. Now, one quick little tip for you is, let's say that you see an EKG. You see that there's an inverted P wave and lead to an upright in AVR. And you're like, oh, Zach said this is focal atrial tachycardia. Before you even assume that, you better go back into the room, make sure that the leads are actually put on properly and that they're not misplaced, because that might be the real reason why it's actually inverted. Okay? So make sure that it's not misplaced, and if it is, it's most likely focal atrial tachycardia. All right, let's say that we have figured out that it's this one or this one. Now we go to the third one. The next one is, let's say that I say, okay, is there P waves? Oh man, I'm looking at this, I don't really see any P waves. Instead, I see these jacked up sawtooth waves. What are these things? These don't even look like P waves whatsoever. These sawtooth waves are usually identifiable as atrial flutter. So this would be something that I want you guys to be thinking about with atrial flutter. Look for sawtooth waves. And usually these sawtooth waves are most visible in leads 2 and leads 3 and in AVF. If you don't see it there, I like to take one other lead that I take a look at, and that's V1. So also take a look at V1. Usually, because of that reentrant circuit, it's going counterclockwise, it produces inverse sawtooth waves in 2-3 AVF. So again, take a look there, see if you find it. Next thing, one more thing to add on to atrial flutter. What do you notice? That these aren't P waves, but they look like they're called flutter waves or sawtooth waves. Do you notice a pattern? 2 flutter waves QRS, 2 flutter waves QRS. So there's a 2-to-1 ratio pretty much going throughout this. And it's constant 2-to-1 throughout the entire arrhythmia. Usually with atrial flutter, if it's regular and narrow, it has a constant ratio. In this case, this is a 2-to-1 ratio. But maybe it could be in other scenarios a 1-to-1, a 3-to-1, a 4-to-1. So that's the important thing to remember, is you need a constant ratio 2-to-1 the entire time. Okay, and we'll talk about why a little bit later. Last arrhythmia, okay? This one I look at and I'm like, whoa. Zach said to look for P waves. I don't even see any P waves. I don't see any flutter waves. I don't see any P waves. So the P waves aren't even there. The P waves in these scenarios, guess what? Because of this last arrhythmia, the P waves are actually usually hidden within the QRS complex. If you get lucky, maybe you might get a kind of a little inverted or retrograde P wave that comes after the QRS complex, sometimes. But this is most likely indicative of what? If I don't see P waves, it's most likely AVRT or AVNRT, which is a type of SVT. All right, so what do we say it could be? It could be AVRT or AVNRT. And again, this was the way that we kind of describe SVT. Again, what do we say we should be looking for with this? Look for either no visible P waves, because they're probably actually hidden within the QRS complex, or if you can, find some retrograde P waves. And if you want to try to find those retrograde P waves, usually they're best seen in the same things that you see for atrial flutter, 2, 3, and AVF. Okay? So that's the big thing that you guys want to be looking for when you're talking about narrow, regular. How do I figure it out? Go through these steps, figure out which one it is. But here's the thing. Let's say that you don't figure it out. That's fine. What I can do is, the first one that I want to try to differentiate with is sinus tach. I really want to try to figure that one out first. Try to find if there is P waves. If not, sometimes what I would do is give them fluids. Usually the fluids will improve and make it more visible with sinus tach. But let's say that you figure out that it's sinus tach. If it is, first thing that you do is treat the underlying cause. What did I tell you the underlying cause was? Primarily for sinus tachycardia. Increased automaticity, which was most likely due to increased sympathetic activity. What was the first thing I told you? It was a very strong stimulator of sympathetic nervous system activity. Hypovolemia. What would you give them? Fluids. That's why I said usually give the patient with sinus tach fluids. They will improve usually. Whereas these other ones, they won't really improve that much with fluids. So that's the first thing I like to do, is give fluids and then try to figure out the other cause. Maybe they have a fever, give them Tylenol. Maybe they have hypoxia, give them oxygen. Maybe they have a PE, I gotta give them heparin or TPA. Figure the underlying cause, treat that. It usually obliterates the sinus tach. Now, if I find out that it's not sinus tach, I got these other 3 that I gotta deal with. Guess what? Treat them the same. How do you treat them? First thing you'll do is in the short term to stabilize them is start off with, so we're going to say treating these, start first with what's called a vagal maneuver. Sometimes these work, sometimes they don't. What you do with a vagal maneuver is you can do a couple things. You can either have them kind of bear down, like they're gonna poop or something like that. You can either do that, or you can take like a little syringe and have them breathe in, kind of blow into the one end and try to push the plunger back as far as they can. That creates the same kind of effect, increasing the intrathoracic pressure and increasing the vagal tone. If you increase vagal tone, what does that do to the AV node? It slows down the conduction and it helps to obliterate this supraventricular tachyarrhythmia. Sometimes it doesn't work though. So what's the next thing that you do? You give a drug that actually blocks it hardcore, but it's a short-acting drug. You can give like 6 milligrams of it, and this is adenosine. Really blocks that AV node pretty well, usually will obliterate the SVT or the AVRT or AVNRT. Sometimes it won't hit the atrial flutter and the focal atrial tachycardia. So what's the next thing that you might have to do for atrial flutter or focal atrial tachycardia if the adenosine doesn't work? You have a beta blocker or a calcium channel blocker. So the next thing that you'll try is a beta blocker, or you can try a calcium channel blocker. The only reason you do one of these is depending upon contraindications. Now, let's say that you try all of these things and it doesn't work and you haven't been able to obliterate this rhythm. The next thing that you can do is you can electrically cardiovert them. You hit them with electricity, and this is called cardioversion. Okay? Electrical cardioversion in this situation. The other reason you can cardioverт them is, let's say that they're in this rhythm and all of a sudden they start becoming hypotensive. Remember these 3 causes: hypotensive, altered mental status, or they start having chest pain or any pulmonary edema. If any of those reasons arise, you cardioverт them before you do anything else because they're unstable at that point in time. But if you tried all of these and it still doesn't work, you can still do cardioversion. But you cardiovert immediately before these if they're unstable. Okay, after we've treated them, stabilized them, then what am I gonna do? Long-term treatment I gotta be thinking about, right? So what am I gonna do to kind of fix this from happening again? There's one particular treatment where you take some radio frequency waves and burn the reentrant pathway in the AVRT or the reentrant EVR pathway in the AVNRT. I'll burn the cava tricuspid isthmus so it doesn't actually create reentrant circuits. I'll burn the ectopic focus with focal atrial tachycardia, and they won't generate, for the most part, these abnormal rhythms. So because of that, that's another option, is what's called radio frequency ablation of the abnormal tissue from the underlying pathophysiology we talked about. It's all coming together, right? Beautiful. We've tried to figure out these causes. We figured them out, we treated it. Now let's figure out the next one, which is narrow irregulars. Now, let's go to the next one, narrow irregular rhythm. I have my differentials, AFib, atrial flutter with a variable block, or multifocal atrial tachycardia. What do? Okay, first thing is I look for P waves. Same thing. Do I see P waves? No. In these situations, I don't really see any P waves. Oh wait, I do. I see one in this one. We'll talk about that one in a second. It does have a little bit of P waves, but it's a really weird one. I don't really like this arrhythmia, but we'll talk about it last. First thing I do, look for P waves. Are they upright lead 2, inverted in AVR, and are we following the PQRST pathway? Let's look at this rhythm. Am I doing that? No, there's no P waves, no visible P waves. Okay, so if there's no visible P waves, what the heck is this little squiggly lines right here that are coming before the QRS complexes? These are called your fibrillation waves. And these fibrillation waves are due to these little multiple ectopic foci that are firing, or those multiple reentrant circuits that are firing. And this is something that'll tell you that this could be most likely atrial fibrillation. So what am I looking for? I'm looking for fibrillation waves. So fibrillation waves, most visible in V1. That's the first thing I look for, fibrillation waves present most likely in V1. The next thing I look for is, after I've tried to determine if it's AFib, is I look for that classic. This one is so classic. Remember, you're looking at those RDAR intervals. It's so irregular, it's insane. Your RDAR intervals are all over the place. So they love to give this, I don't know, it's a stupid term, but they like to call this an irregular rhythm. Okay, so sometimes you might see that come up on your exams because it's just so awkward of a rhythm. All right, you see the fibrillation waves, you see this super abnormal irregular rhythm. Again, this is the one that I want you to see is the most common type of narrow irregular. Remember, these fibrillation waves, we kind of put like a little F with it, right? So these little fibrillation waves that you're seeing here, sometimes is little f. Again, if you see fibrillation waves, most common in V1, and an irregular rhythm, it's AFib. Next thing, let's say that I go to the next type of arrhythmia here. I don't see fibrillation waves, but I don't see P waves. But these look familiar, don't they, guys? Oh, wow. It's like flutter wave again. Those sawtooth waves that I was talking about before. But I thought atrial flutter was regular. Remember, I told you it can also be irregular. So with atrial flutter, this is the next one that I want you to remember. Again, you're seeing sawtooth waves. You're seeing these nice little sawtooth waves. And again, where are they most visible? Test your knowledge. 2, 3, AVF. You don't see it there. Take a look at V1. Here's the thing that we got to talk about, because we said atrial flutter over there was a regular rhythm. Let's explain why is it irregular here. Look at the flutter waves. 2 flutter waves, QRS complex. 1 flutter wave, 1 QRS complex. 2, 1, 1, and then 2. You keep going back and forth between a 2-to-1 ratio and a 1-to-1 ratio. That should make sense. If I have 2 flutter waves and then a QRS, that's going to produce a different distance between the R and R intervals. That's common sense, right? So because of that, that's why we use that term variable block, where they have, in this case, a 2-to-1 and a 1-to-1 type of ratio. And that is where we get that term, that variable AV block. Okay? All right, beautiful. Next one. We have no fibrillation waves. We have no flutter waves, but I do see P waves. I see a couple of them, but they don't look anything like they should. If I see these and I see no like normal P waves, oh wait, I see one, because I have to have something to compare to. That's why I hate this rhythm. If you don't have any kind of normal P waves to compare to, it's kind of hard to identify it as being abnormal. But let's say I have a normal sinus P wave in this situation. And I look here at this P wave and try to compare it. Oh wait, that's inverted. That's not the same. Boom, there's one. That one's kind of pointed. That one's more rounded. That's a different one. This one looks all kinds of jacked up. It's like an M. That looks nothing like that. And this one does kind of look like it. But I have 3 morphologically different P waves in this situation. And again, it's because they're different, means that they're coming from different areas in the atria. One area is firing, another one is firing. It's producing different P waves. That's why they're different morphologies. And some of them may be closer to the AV node, some may be farther from the AV node. And that's why the R to R intervals are different, because it's depending upon where that ectopic focus is in the atria, maybe a farther distance or shorter distance. So what is this one here called? So with multifocal atrial tachycardia, what do you guys need to remember, besides this being kind of a stupid arrhythmia? It is 3 or more morphologically different P waves. The next thing is that it has to be tachy. The reason why it has to be tachyarrhythmic or greater than 100 beats per minute is because there's another arrhythmia that looks just like multifocal atrial tachycardia, but it's a normal rate. That's called a wandering atrial pacemaker, so don't confuse them. The next thing I want you to remember with multifocal atrial tachycardia is that it's due to they have some underlying disease that's causing this. And if you fix that, it fixes the issue, kind of like sinus tach in a way. This is usually due to some type of lung disease like COPD or maybe even a pulmonary embolism, or due to an underlying heart failure. These are 2 big conditions you guys want to remember with multifocal atrial tachycardia. Okay, boom. We've determined which one of these arrhythmias it is based upon our algorithm and our differential. The next thing we have to do is start treating it. Let's treat these the same way we would treat up here. You can try a vagal maneuver on these ones, but generally it's not going to improve. So you can try it, but generally it doesn't really work. So most likely if you see a narrow irregular, you can try adenosine. Adenosine usually doesn't work as well either. So the next thing that you're going to go to here is you're going to go adenosine, and you're probably going to go most likely first, if you see narrow and irregular, you're most likely going to reach first for a beta blocker or a calcium channel blocker. Because again, which one did I say is the most common cause? AFib. AFib doesn't usually respond to adenosine. You can give it a shot, but most likely you're going to go to a beta blocker, calcium channel blocker first. After you've tried that, let's say it doesn't work. If that doesn't work, the next thing you're going to do is the same process up here, cardiovert them. Hit them with electricity to try to restart that heart and to generate a whole new rhythm. Again, big thing you guys can't forget here is that if any of these arrhythmias at any point in time become unstable, what do we define that as? Hypotension, pulmonary edema, chest pain, or an altered mental status, you hit them with electricity regardless. You can also do it if this isn't working, okay? Now, after I've cardioverted them, I have to have some long-term treatments that I can use to prevent these things from happening. Now, we're going to have another lecture on atrial fibrillation because it's one of the most common arrhythmias, so we'll have to talk about this one in more detail. But for just the basic part here, long-term treatments of these arrhythmias, again, same thing, burn the abnormal cavo-tricuspid isthmus, burn the ectopic foci, burn the multiple ectopic foci in these situations, and that is called radiofrequency ablation. The other thing that you also want to consider, especially for AFib, so if someone has atrial fibrillation, okay, sometimes atrial flutter, but AFib is the big one that you don't want to forget. You have to do what's called a CHAD-VASc score. And that, you can plug that into your little MD calc. It's like, you know, there's a particular thing that you're looking for in a point system here. We're not going to go into too much detail on it. But if you calculate this and it's greater than 2, that is telling you that they have a high need to be anticoagulated. So what you'll do is you'll start them on anticoagulants, okay, to try to prevent these individuals from developing a deadly embolus that can spread to multiple different areas. The most deadly one, or scary one, is into the brain, leading to a stroke. So that's the big thing, is radiofrequency ablation and AFib. Really got to try to anticoagulate them if there is need based upon that score. Okay? And sometimes they may need long-term management with a beta blocker or a calcium channel blocker. Same thing, if someone has atrial flutter, they may need a beta blocker long-term. Okay, so we talked about the narrow irregular. Now let's hit our wide and regulars. Let's talk about our wide regulars, okay? We got our VTach, SVT with aberrancy. These are the two big ones. Again, anti-adromic AVRT, it can happen, but I want us to talk about it more with the wide irregulars. So let's focus on VTach and SVT with aberrancy. Here's the thing. When you look at this one, you'll notice, wait, Zach, how do I know? I thought there's supposed to be 2 rhythms because there's 2 things that you wanted to talk about primarily. That's what's tough about this one. With this wide regular rhythm, or what's called a wide complex tachycardia, it can sometimes be very, very difficult to differentiate. Is this rhythm here a VTach or is it an SVT with a bundle branch block? How in the heck do I know the difference between them? Because they can look pretty much the same. So here's a couple ways that you should remember them. So let's say that we talk about VTach here, and let's say that we talk about SVT over here, and we just kind of like make little comparisons between these two about how SVT with a bundle branch block, let's be more specific, bundle branch block, and how do we differentiate these? All right, first thing, when you're looking at them, they're both going to have wide regular rhythms, but VTach, these QRSs are even wider. How wide we talking, baby? Usually we're talking greater than 0.14 seconds for their QRS complex. For SVT with aberrancy, it's usually less than 0.14 seconds. So there's one identifier, okay? The next thing is, you look at the P waves to see if you can see. Sometimes you may get lucky where you see a little inverted or retrograde P wave snuck within the QRS complex. That's called AV dissociation. Okay, so with VTach, this one has AV dissociation. Okay, with the SVT with aberrancy, there is no AV dissociation. Okay, that's important to remember. Okay, the next thing here, with VTach, there's something we'll talk about in another EKG series where it's called extreme right axis deviation. Usually VTach has extreme right axis deviation, whereas SVT with aberrancy does not have extreme right axis deviation. And last but not least, which I think is probably one of the most important ones because sometimes this can be really difficult to identify, is usually VTach is a history of some type of cardiovascular disease. Okay, usually cardiovascular diseases and older, greater than 35 years of age. SVT with a bundle branch block is not very common in individuals with a history of underlying cardiovascular, like structural heart diseases. Okay, so usually it's no history, no significant, let's put significant past medical history of cardiovascular diseases that are usually structural in origin, and usually less than 35 years of age. So again, these are not the same. How do we differentiate them? These factors. But in real life, who cares if it's this one or this one? You want to know why? Here's why. If I treat someone who has SVT with a bundle branch block, okay, and they actually have VTach, I can kill them. If I treat someone who has VTach, right, but they actually have an SVT with aberrancy, it may actually improve their arrhythmia, or it may not really affect it at all. So what would you rather have? Right? So that's why pretty much every time you see someone who has a wide, regular tachycardia, you should always be the first on your differential should be, the most common is going to be VTach. Okay? Treat it empirically in that sense. The reason why is, if you treat, again, another reason, if you give adenosine, because that's the common treatment for SVT, if they have antidromic AVRT, it can also worsen the situation because you do not give AV nodal blockers to people with antidromic AVRT, especially if they have some other pre-excitation like AFib or AFib associated with the antidromic AVRT. So again, off my soapbox, most common, treat for VTach. Just be careful, unless you know it's SVT with aberrancy, you treat it as though it's VTach. So with that all being said, let's assume that this is VTach. How do we treat it? Okay, with VTach, okay, the primary thing that you're gonna do for treating this situation here is you're gonna give them something called amiodarone. Amiodarone is an antiarrhythmic, okay? So it's gonna help to try to regenerate and kind of set their normal rhythm. Another drug that can be considered instead of amiodarone is another drug called procainamide. Okay, and there is other ones that you can try as well, but these are usually the better options in these situations. So let's say you try these first, amiodarone or procainamide. If these do not work, then the next thing that you're gonna go to here is you're gonna put pads on the patient because VTach is very unstable. Okay, we're treating this as though it's stable, but it can quickly become unstable and break down into what's called VFib. So you should always have the pads on them, and if you've tried the amiodarone or procainamide and it didn't work, you can cardiovert them. But have them pads on them in case they become unstable, because then you can still cardiovert them. Or worst case scenario, defibrillate them. The only difference really between synchronized cardioversion and defibrillation is what the word says. Synchronized is you're timing that electrical jolt that you're going to give them to line up with the R wave, okay? That can sometimes be difficult in irregular rhythms though. So again, if it's regular, you can cardiovert them. If it becomes unstable, you can also cardiovert them. If it's SVT with aberrancy though, okay, so if it's SVT with a bundle branch block, they're going to benefit from the adenosine, okay? So you can consider adenosine in this situation as well. And here's why they say sometimes in the algorithms, you'll see treat with adenosine first, because if it is SVT with bundle branch block, it'll usually obliterate it. If it doesn't, then it's usually VTach, monomorphic VTach. But again, you give adenosine to someone with VTach, it could worsen the scenario. So if you give adenosine, just be cautious, okay? And then the antidromic AVRT, that was the last one there, you're going to treat it kind of the same way that you would treat VTach as well. So antidromic AVRT, give them procainamide or amiodarone, and then cardiovert them. After you've done this and you've stabilized the patient, one last thing I need you guys to be remembering here. Long term, what do we do? Well, we kind of already talked about it a little bit, which you've seen kind of a pretty consistent basis with these. Radiofrequency ablation. Burn the crap out of these abnormal ectopic areas with SVT or with the VTach or the antidromic AVRT. The other thing though is with VTach, this is a very nasty arrhythmia and you gotta be very careful, okay? Usually VTach, the most common cause, do you guys remember? Go back and let's see. Triggered activity was one of the big reasons we said, and it was related to the DADs. What was the most common one I told you for the DADs? Ischemia. So because of that, you want to look for the underlying cause, and that is most likely an MI. So look, after you've stabilized them, generated their normal rhythm again, look at those ST segments, look for elevation, depression, check the tropes, and if there is, send them to the cath lab to get a PCI. After you've figured that out though, the next thing is, do they need, sometimes with VTach, they may need an automatic, like an implantable cardiac defibrillator. Because if they go into VTach again and they're not at the hospital, what can happen? They can die. So you want that defibrillator to identify it and then hit them with the electricity to regenerate that rhythm. There's a lot of indications for these that's past the scope of this lecture. So let's just kind of assume AICD for recurrent or malignant VTach. Okay? Boom, roasted. Let's move on to the next thing, which is the wide irregulars. Last one here for the tachyarrhythmias. Wide QRS irregular rhythms, we have our differential. Polymorphic VTach. Let's do this thing first. Let's hit it right out the way. This can sometimes be very difficult to identify, okay? If you have a polymorphic VTach, you want to look at the QT interval before they started going into this nasty little arrhythmia here. So this is usually a polymorphic VTach. How can you tell if it's polymorphic? You see the QRS waves? They look different. So they have different morphology. So because they're different morphology, different amplitude and stuff like that, that's why it's said to be a wide and irregular, okay? First thing I like to look at is, was there a normal QT interval before they went into this deadly kind of arrhythmia? So that's the first thing we got to address. If it's polymorphic VTach with a long QT interval, how do I determine that? Again, usually you want beforehand, before they even went into this type of rhythm, they had some type of identifiable kind of rhythm here that you could have looked at. And what you're looking at is you're measuring that QT interval and seeing if it was prolonged beforehand. What is considered to be a prolonged QT interval? There's a lot of different numbers. I like to just say if I see a QT interval that's approaching, it's either greater than or equal to 500 milliseconds, I'm going to start pooping my pants a little bit because this is most likely torsades de points, okay? Polymorphic VTach with a prolonged QT interval. So again, which one are we thinking this could be? Torsades de points, okay? So that's the first thing. I find this abnormal waves, I check my QT, I find out it's prolonged. If it is not prolonged, then it is polymorphic VTach with a normal QT interval, or there's one other condition. So let's say that you have someone with a polymorphic VTach with a normal QT interval, okay? And the other scenario is you have someone with AFib with Wolff-Parkinson's-White syndrome, okay? Wolff-Parkinson's-White syndrome. And these are your two that you're trying to figure out here. Usually if someone has AFib with a bundle branch blocker aberrancy, that's actually going to be kind of one of the slightly easier ones to identify, and plus it's kind of one of the most common, so we'll talk about that one last. But if I'm trying to look at the difference between these two, it's sometimes very, very difficult. It really is. With polymorphic VTach with a normal QT interval, and versus AFib with Wolff-Parkinson's-White syndrome, sometimes it can be so difficult to differentiate them. One of the things that may help is that AFib with Wolff-Parkinson's-White syndrome has pretty high rates. Pretty high rates. And remember why? What kind of Wolff-Parkinson's-White syndrome is it most likely? Antidromic AVRT, which means the electrical activity from AFib is going where? Right through the bundle of Kent into the ventricles. So the atrial rate and ventricular rate can almost equal one another. The problem with that is that AFib and Wolff-Parkinson's-White syndrome is if you give this an AV node blocker, so let's say that you gave this person an AV node blocker. Now, all the electrical activity that's going from AFib, coming from the AFib, it won't go to the AV node, which is highly regulated. It'll only go through the bundle of Kent. And because of that, if you do this, this can quickly break down into VFib. Okay, it can generate some really nasty rates. So that's why the only thing that you want to just be aware of if you're trying to really kind of differentiate the treatment differences is that if they have AFib and Wolff-Parkinson's-White syndrome, don't give them any kind of AV node blocker. And alpha, so what are those? You guys remember them? ABCD, adenosine, beta blocker, calcium channel blocker, digoxin. Stay away from those. So that's why, since that is the case, it doesn't really matter if you determine if it's polymorphic VTach with normal QT or AFib with Wolff-Parkinson's-White syndrome. You want to know why? As long as I avoid AV node blockers and I treat these the same, I should be okay. So, what is the treatment in this situation for a polymorphic VTach with normal QT and AFib with Wolff-Parkinson's-White syndrome? What I'd like to start off with first is treat this with amiodarone. So I'm going to treat this with amiodarone, or I can try procainamide and see which one of these, see if they work. If I've tried this, amiodarone or procainamide, and it doesn't work, what do you think I do? Same thing I did with VTach, cardiovert them. So the next thing I'm going to do is I'm going to cardiovert the patient. If at any point in time though, here's the thing you got to be careful of. With polymorphic VTach, you may cardiovert them synchronized. That's what they'll say, synchronized. Here's the problem though. Sometimes the machine has difficulty kind of syncing up with those R waves because of the irregularity in how fast it's going. So sometimes cardioversion, really this may be more defibrillation if you see this type here, okay? And again, AFib with Wolff-Parkinson's-White syndrome, the treatment is going to be the same as polymorphic VTach with normal QT. Okay? The only thing that is different is that you avoid AV node blockers at all costs. Adenosine, beta blockers, calcium channel blockers, and digoxin. One more thing here with the polymorphic VTach with prolonged QT before we go into AFib with bundle branch block is that with this one, this is the one that actually thankfully is kind of the most weird and different type of one. With someone having polymorphic VTach with prolonged QT and suspecting it's torsades de pointes, do you guys remember the underlying pathophysiology behind torsades de pointes? It was an EAD, right? What were the big causes for EADs? Hypokalemia, hypomagnesemia, or hypocalcemia. And the offending drugs, the A, B, C, D, E drugs. So what would I do here? Well, you're probably saying, oh, give them potassium and magnesium. You're so right. Give them mag empirically though first. You give mag sulfate. Then check their potassium levels and make sure that it actually is low, then replete the potassium levels. So what would you do for torsades? You're going to give them magnesium sulfate and then replete potassium levels. These are the two ones if it's low, okay? Then what else? Discontinue the offending medications or lower their dosages. Antiarrhythmics, antibiotics, antipsychotics, antidepressants, antiemetics. Now, the other thing that you could do, you just want to write this down just as a side. Sometimes you may stabilize them with the mag, repleting their potassium, and then getting rid of the offending medications. Sometimes though, after you've stabilized them, they still may have a prolonged QT interval. And you want to prevent them from going into another torsades de pointes. So what sometimes they may do is do what's called overdrive pacing, or give another drug which is called isoproterenol. And what these drugs do is they kind of increase the heart rate a little bit. If you increase the heart rate a little bit, that shortens the QT interval, which is going to decrease the incidence of them going back into another torsades de pointes. So you understand? Okay, beautiful. Polymorphic VTach with prolonged QT, greater than 500, mag, replete potassium, discontinue meds, overdrive pace. These two, polymorphic VTach with normal QT or AFib with Wolff-Parkinson's-White, amio, procainamide, cardiovert. But just be aware you may have to defib them because the machine won't sync sometimes. And then with AFib with Wolff-Parkinson's-White, for the love of goodness, avoid the AV node blockers. A, B, C, D, right? Last thing here. With the AFib and a bundle branch block. AFib with a bundle branch block, believe it or not, or also called aberrancy, is the most common type of wide irregular. The way that you can differentiate this one from all these others is because usually the rates are not as fast. So it's still fast, but not as fast. But here's the big thing. The QRS morphology is usually the same. But because the person has AFib, where there's multiple ectopic foci that are firing and it's going down that bundle branch system, what did we say was a common theme with AFib? The R-to-R intervals were never the same. It was so irregular. But because we hit a block, it's not going down your normal conduction pathway, so it widens that QRS complex. So look for a QRS morphology to be relatively the same, not different. And then if you can find that, or you've ruled out all the other causes, then you treat them with a beta blocker or a calcium channel blocker. If that doesn't work, you cardiovert them if that happens, okay? Now, the last thing that you guys need to see here is, again, let's take a look over here at these rhythms. If you look here at this one, again, we said that this was the polymorphic, right? You could see the constant differences between this QRS and these QRS. You see how this one has different R-to-R intervals though? Different R-to-R here, different R-to-R here, different R-to-R here. But all the QRS complexes are exactly the same. Pretty much the same morphology. Which one would this lead you more towards? AFib with the bone to branch block. What would this one lead you more to? These other three. How do we differentiate this from this? QT interval. Prolonged, not prolonged. How do we differentiate these two? Sometimes you can't. Treat them empirically. Got it? Last thing is long-term treatment. After you figured this out, how do you do what's the long-term treatment in this situation here? So the long-term is going to be the same as we've talked about before. Radiofrequency ablation of the abnormal pathway. And in someone who's developing these abnormal rhythms like polymorphic VTach with a normal QT, or they have some other issue here like VFib, which we'll finish up with, you want to consider an implantable cardiac defibrillator if they have recurrent VTach or VFib. Okay? So that leads us to the last thing to finish this up. Why are these so dangerous? Why are these so dangerous? Okay? One of the reasons why is that sometimes these kinds of arrhythmias can quickly break down into what's called VFib. And VFib usually produces no pulse, and they can be very, very dangerous. So in these situations with VFib, you go with CPR, chest compressions, epi, and defibrillate. Do it again and again and again. So again, that finishes up our tachyarrhythmias. Let's hit it home with our bradyarrhythmias. All right, bradyarrhythmias. So now we said, okay, is it too fast, too slow? It's too slow. If it's too slow, we have to kind of look at our EKGs a little carefully here. The first one that I want us to talk about here, that you guys think about right away, is it sinus bradycardia? That's the first thing I need you guys to be thinking about. Is it sinus bradycardia? How do I determine that? I'm looking for my P waves, right? So here's my P wave here, and here's my P wave here. Is after every P wave there is a QRS complex? Yes. If after every P wave there's a QRS complex as in a normal P wave, that is sinus bradycardia. It's just moving slower than your normal rate. Okay, you've determined that it's sinus bradycardia. What's next? Next thing is, let's take a look at this next arrhythmia. This next arrhythmia, same thing. Do you have P waves? Yes, I do have a P wave. After every P wave, is there a QRS complex? Yes, there is. So what's the problem with this? Is this sinus bradycardia? Now this is the next step that you look at. Look at your PR interval. So go before the P wave, all the way up until you get to the Q wave. That's our PR interval. If the PR interval is greater than 200 milliseconds, that is considered to be too long. That's a prolonged PR interval. So again, PR interval greater than what? 200 milliseconds. What is this? This is a first degree heart block. Okay? Now, you determine that it's not sinus brady. You determine that it's not a prolonged PR interval. The next thing that you got to go to is, okay, let's take a this next rhythm here. Okay, what's this one here? Do I have P waves at every point? Well, here's my P wave. Here's my P wave. I got two P waves here. Okay, so I got a couple P waves. After every P wave, is there a QRS? One here, one here. I don't have one there. I dropped a QRS. Okay, so I know that there's not a QRS for every P wave. Okay, that's interesting. Let me take a look at the PR interval. Let's see if there's anything abnormal with that. So I'm gonna look at my PR interval from here to here. That's long. I know I'm making it up because I don't have my boxes there, but again, if I did, it would be too long. Then I'm gonna look at this one. That's even longer. And then I dropped my QRS. Remember the little poem, longer, longer drop, you have a winky Bach. That is a second degree heart block, Mobitz 1. Remember I said the winky Bach was a drop QRS. So if you see a PR interval that is getting longer and longer and longer and longer progressively, and you drop a QRS complex, then this is a second degree heart block, Mobitz 1. And that dropped QRS is called a winky Bach. Beautiful. Let's move on to the next one. Next situation here, check my P waves. Do I have a P wave? And after every P wave, is there a QRS? Well, there's my next P wave, dropped a QRS. Here's my P wave, QRS. Here's my P wave, QRS. Here's my P wave, dropped a QRS. Okay. So if I'm kind of looking here, I'm seeing something very interesting where not every P wave is followed with a QRS complex. Okay, that's interesting. What's the next thing I do? Check my PR interval. You obviously can't tell here because I don't have the little boxes, but my PR interval is normal. I'm going to tell you guys that. My PR interval in this situation is normal. So I have a normal PR interval, but I also have dropped QRSs out of nowhere. If your PR interval is normal and you're dropping QRSs out of nowhere, this is a second-degree heart block, Mobitz 2. And there's another interesting second-degree heart block that I want to talk about. So now let's take a look at this next one here. Kind of similar here. Again, take a look at the P wave. Is there a QRS? Yes. P wave, is there a QRS? No, I dropped a QRS there. P wave, QRS. And then again, P wave, dropped a QRS. P wave, QRS. P wave, dropped a QRS. P wave, QRS. There's a pattern to this if you guys see it. I have a normal PR interval in all of these. Okay? I want you guys to remember that. For this situation, there's a normal PR interval. And again, I can tell that because it's not greater than 200 milliseconds. And I'm dropping QRSs. But I'm doing it in a very weird pattern where the P wave is being generated, no QRS, another P wave, then a QRS. So that means, and that's happening every time. You see these two that are always lumped together? That means for every 2 P waves that I'm firing, I'm only getting 1 QRS pattern. So I have a 2-to-1 second-degree heart block. Okay? It's kind of like a kind of a variant of the second-degree heart block Mobitz 2. Okay, the last one here is looking here. Okay, let's see. I got my P wave here. I drop a QRS, or I don't even produce a QRS in this situation. I got a P wave, and then, oh, I produce a QRS, but this QRS don't look nothing like that QRS. Why? It's wider. So now I'm having dropped, I have a normal PR interval, so let's put that down. PR interval is normal, and I'm dropping QRSs, and my QRS complexes are super wide. That's telling me that I'm not going through my normal conduction. It's not going AV node down. It's stopping at the AV node, and then the ventricles are depolarizing on their own. That means there's complete disassociation between the atria and the ventricles. There's no connection between them anymore. Once that happens, where you have a normal PR interval, but you're dropping QRSs and the QRSs are wide, and if you calculated the rate between this QRS complex and that, it's probably going to be equal to the ventricular rate, which is about 20 to 40 beats per minute. If you calculated the rate between P wave to P wave, that'll probably be around the actual SA node rate, which is around 60, 80 beats per minute. So because of that, they're usually going to beat at their own intrinsic rates because they're completely disassociated, and that is a third-degree heart block. Bad. Now, in these situations, here's the thing. These arrhythmias are the ones that you got to watch out for. All the other ones are pretty much benign. You don't really have to deal with them. They're usually pretty much asymptomatic. But in these, second-degree Mobitz 2 to third-degree heart block, the problem with this is their heart rates can drop pretty low because that conduction through the AV node is really jacked up. Remember the formula? Cardiac output equals heart rate times stroke volume. If you increase heart rate, what happens to the cardiac output? It increases, right? If you decrease heart rate, you decrease cardiac output. Well, if I'm really dropping my heart rate here, what's going to happen to my cardiac output? I'm going to drop my cardiac output. Then the next formula, if you have your blood pressure is equal to cardiac output times the total peripheral resistance. If you decrease cardiac output, you decrease blood pressure. So now from this situation, I'm also going to have decreased blood pressure. If I drop the blood pressure enough that the patient goes into starts having significant hypotension, so their blood pressure is really dropping, they start having an altered mental status, or they start having chest pain or any types of like pulmonary edema, this is considered to be unstable and you have to treat them. If they don't have really any of these things, you don't really have to treat them. You can just kind of monitor them. But if they experience any of these situations, they're considered to be unstable. We got to treat them. So what do we do? So first thing you got to do is we're going to give them atropine. So I'm going to start off with atropine. What the heck is atropine? I just want you to remember atropine is going to decrease your parasympathetic nervous system effect on the AV node. In other words, it's going to block acetylcholine from binding to the AV node. If you block acetylcholine, what did acetylcholine do when we talked about decreased automaticity? It slowed down conduction. If I block acetylcholine, now I have nothing inhibiting conduction. It's going to increase conduction. That should jack up the heart rate a little bit. All right, so sometimes atropine doesn't work. So sometimes what we have to do is we have to kind of not just oppose the parasympathetic, but increase the sympathetic. So if I give something like epinephrine, right, epi, that's going to increase my sympathetic nervous system activity. What did the sympathetic do? Increased AV conduction, increasing heart rate. So I oppose the parasympathetic, increase the sympathetic. Sometimes that may bring the heart rate up. Sometimes it doesn't. So sometimes what you may have to do is do what's called pacing. So you may actually have to pace the patient. And there's a couple different types. One is you can put it on their chest, called transcutaneous. The other one is you kind of float it down the venous circulation. It's called transvenous. And then sometimes in situations where it's particularly a third-degree heart block, you may need what's called a permanent pacemaker to be put in place. Okay? So this is the thing that you're going to go through once they have any of these instabilities: atropine, epi, pace. Okay? After you've stabilized them, the next thing you have to do is you got to figure out what was the underlying cause for all of these dang issues here. And it was most likely what? Do you guys remember? Conduction block. I told you there was a couple things I needed you to remember that were the common causes of conduction block. Do you guys remember the first one I told you? Inferior wall MI. So we have to treat underlying, so treat the cause, basically. And what were some of these causes? So the first one we said was an inferior wall MI. What was that due to? An RCA occlusion, right coronary artery occlusion. What do you do for this? Look for any signs of STEMI, NSTEMI, check maybe some positive troponins. Maybe they were positive. What do you do once you determine that? Get them to the cath lab. And then once you get them to the cath lab, they get a percutaneous coronary intervention. We put a stent in there. That may help it. The next thing is, after we've done that, is we move on to the next step. What was another particular cause? Another big one that I wanted you guys to remember was hyperkalemia. Remember, hyperkalemia can really be a nasty condition. It can really affect those electrical activities. What do you do for this situation? In hyperkalemia, there's a particular protocol that we go by. You first give them calcium in the form of calcium chloride or calcium gluconate. That stabilizes their cardiac membranes. After you do that, you give stuff to shunt potassium into the cells. And the things that you give to shunt potassium into the cells is insulin, but you don't want to overcorrect them and drop their sugars, so you give them a little bit of sugar with D50. And then insulin will push potassium into the cells, and albuterol will also push potassium into their cells. And so that'll kind of lower the circulating potassium levels. The other thing is sometimes when high potassium occurs, it can produce acidosis. So sometimes you may have to give a little bit of bicarb to treat the acidosis. And then finally, you may need to give some Lasix to pee some of that excess potassium out as well. So these are going to be things that you'll go by to treat the underlying cause for those two issues. So we said inferior wall MI, so we had hyperkalemia. What was the other big thing that I needed you guys to remember? The other big thing that I needed you guys to remember here is overdose from the calcium. They had too much calcium channel blocker, too much beta blocker, right? So if they took too much of a beta blocker, or too much of a calcium channel blocker, or too much of digoxin, all those things was blocking the AV node. What do I give for a beta blocker? I give glucagon. What do I give for a calcium channel blocker? I give them calcium. What do I give if they have digoxin? I give them Digibind. Okay? We're almost done, Ninja Nerds. The next thing, high yield, big one. Lyme's disease was another one I told you don't forget about. Lyme's disease. Lyme's disease was caused by what type of infection? It was a tick bite, right? That released the Borrelia burgdorferi and really jacked up the AV node. In this situation, you're probably like, oh yeah, Lyme's, you treat it with doxy. Yeah, you'd think. It's actually ceftriaxone. So in this stage of Lyme's disease, it's more of a severe stage, so you actually have to give them a drug called ceftriaxone in this situation. And then the last thing that I want you to remember is that there could be other causes other than conduction block, not as important, but remember, there was the ones that was like hypothermia. What would you do for hypothermia? Rewarm them. And hypothyroidism. What do you do for hypothyroidism? You give them thyroid hormone, right? So you give them what's called a levothyroxine if they have something called myxedema coma, which can produce some pretty severe bradycardia, sometimes heart block. So again, these are the things that you have to remember. Treat the underlying cause because that may prevent these continuous bradyarrhythmias from occurring. Ninja Nerds, we finished arrhythmias. All right, Ninja Nerds, in this video we talk about arrhythmias. I hope it helped. I hope you guys did like it. And as always, until next time.